Thank you, Professor Rat, for this magnificent lecture. And now the floor is for Dr. As'ad Ahmed. Dr. As'ad is a well-known teacher and sport medicine guy, also interested in trauma and osteotomies around the knee. And he will talk about the meniscus. The floor is yours.
Yeah, thank you. Good morning, everybody. I think they discussed everything. So this may make my presentation easier. Now, preserve the meniscus. All lectures say about preserving the meniscus, and we will describe a new technique and cost-effective technique for meniscus repair. Before we start, what would you do for this? This is 17 years old. He has this complex radial, vertical, lateral meniscus tear. Who will do meniscectomy? Anyone will do meniscectomy? Who will do repair? Okay. Now, on the other hand, this is 72 years old. She's old, yeah, and she has. We went to resect a flipped meniscus part, and if you want, we found this complete radial tear. What to do? Meniscectomy, nothing or repair. Who would do repair? Who would do repair? Who would do meniscectomy? Okay, nothing. So, preserve the meniscus. A knee without meniscus, like a car without shock absorber, so there will be a damage to the knee, and all the discussion before was about that. And to have a functioning meniscus, we should have preserved continuity from anterior to posterior root. And if we have a root tear, there will be extrusion of the meniscus, and it will become functionless meniscus. The same is for complete radial tear. So if we have complete radial tear, this means a functionless meniscus. So root tear, unfortunately, commonly missed in Jordan. So we have to take care how to diagnose and how to treat, and the MRI signs of root tear. What happens if not treated? We know from the literature there will be persistent pain, progressive cartilage wear, and osteoarthrosis. And if you delay the treatment, this is the problem, there may become more extrusion and may become difficult to reduce and treat. So in my practice, what we do in all cases of complete radial tear or root tear, we do repair as soon as possible, with or without high tibial osteotomy, and this is according to the age of the patient, degree of osteoarthrosis, and the presence of malalignment. Look here, a 48 years old, she has root tear with this degree of osteoarthrosis. What to do? Totally? So she's young, so we check the alignment, we planned osteotomy, and we did root repair, microfracture, and osteotomy. And look here, just compare after 15 months how the joint line is preserved. And this is common in my practice. When I restore the meniscus, I will see in the follow-up that the X-ray show this, that the joint line is preserved. So here another case, and this is about meniscus extrusion. You see, this patient has meniscus extrusion without root tear and without radial tear, and she had this degree of osteoarthrosis. So what we did, we mobilized and centralized the meniscus, and we did high tibial osteotomy. And you see here how the joint line is preserved after 1 year. So meniscus extrusion also in young adult. This is in young athlete. This is a case of ACL tear. He has a radial tear at the posterior horn of the lateral meniscus with extrusion, and you see here how it's extruded. So what to do? Again, this is close to the root, so we deal with it as a root, and look how the tension back to the meniscus. It's reduced and the tension is back. So after that, we did ACL reconstruction. Because knee stability is important for successful meniscal repair, and a stable functioning meniscus is important for knee stability. So this is very important. So when you do meniscus repair, you have to take care of the alignment, knee stability, the repair technique, and the biology. Which technique? If you have radial tear, the best is to do side-to-side repair, and many use all inside or out-end technique. But this is not true perpendicular, circumferential, compressive tear. So the best is to have circumferential stitches. This is a true suturing technique. But most of people, the surgeon bought the tie inside the joint. This is a problem. And in other types of tear, you have the all inside. This is for the posterior half of the meniscus. Many people use this, many surgeons. The problem that it's oblique meniscus penetration, not vertical, so it's not strong, it's weak. It needs a strong meniscus wall, so if you have complex tear the bed, so you cannot use it. There is a risk of neurovascular injury, it's expensive, and there is a higher risk of cyst formation, so all these are disadvantages. The other is out-in, and commonly used for the anterior half of the meniscus. The problem, again, it's oblique meniscus penetration. You use 2 needles, and between these 2 needles, you may have soft tissue entrapment and the risk of saphenous nerve injury if you use it in the posterior medial part. The more commonly used in Jordan, the spinal in-out technique using the spinal needle, and this is again oblique meniscus penetration. There is a wide gap between the 2 needles, and this carry a higher risk for saphenous nerve injury, especially if you use it for the posterior medial part, and it's more expensive than the out-in technique. Another modification, which is the hybrid in-out technique guided by a spinal needle, and this makes the gap between the needle less, but still there is a risk for tissue impingement and saphenous nerve injury if you use posterior medial. Again, this technique is oblique meniscus penetration. So this is impingement, oblique. So imagine that you have like this torn, degenerated meniscus. If you go like this is very weak type of repair. So we have challenges in meniscus repair. To provide a strong repair, how to avoid soft tissue entrapment and saphenous nerve or neurovascular injury, how to deal with more complex tears, radial tear and more complex types of tear, and how to decrease the cost of the meniscus repair, especially if you use many stitches. So we have solved almost all these problems by our new technique, which we call it the limited capsule bridge technique. This is the drawing of the technique done by my daughter, Sarah. Now, it's like this. We pass a vertical suture, we progress a BDS loop, and then load the suture. We go back to the capsular rim only, not out of the skin. Then we shift it up, and then we penetrate again the meniscus inside, and we load the second suture, and we pull up the needle out of the skin. Now we have 2 loops holding the vertical suture, and we pass it out of the skin through the same puncture, and we make the knot. We have tried it more than 400 cases, and we don't have any single case of saphenous nerve injury. So the advantage of this technique is a vertical suture, so strong and suitable for complex types of tear. We can control the direction, we can go far posterior with this technique. A strong suture primary, we can use it to test reduction, and for reduction of displaced meniscus, it's a cost-effective technique. And there is no or maybe very minimal risk of neurovascular injury because of the vicinity of the suture limbs. And we use very small accessory incision for knot tying. And you see here, look, we use, I'm doing a lot of shoulder surgery, so we use that technique the same. I use knot pusher to tie the knot, and you see here, this was used for repair of very posterior radial tear. And you see after knotting the first one, and after the second one, we make like this, we cut the suture, and you see how small is the accessory, even doesn't need suturing. So the disadvantage need more time, more skills, and maybe unsafe for the most posterior part of the meniscus. So, but again, we modify technique for that. We use either the technique we use for rump lesion, and we can use posterior medial or lateral portal to tie the knot, or even in case of ACL reconstruction, if the ACL is absent, we can use even the anterior portal to tie the knot. In other cases, look like here, this is a complex lateral meniscus tear. We use the inside out, like from inside the joint, we go make a suture around the meniscus, pass the suture limb, and then after that penetrate the torn meniscus by mini lasso, pass the suture inside the meniscus, and after passing the other, we make a knot tying. So this is very strong repair technique. And we used for more complex cases. This is a case, it looked innocent, but it's not innocent because here the meniscus is degenerated, it's weak. So this patient failed conservative treatment. We went inside, look, I think we have discussed with Dr. O'Brien this case before. Look, it's hypermobile meniscus, and you look, the upper part is very thin. So this is very weak degenerated meniscus. So what to do? We have to take care of refreshment and repair technique. So we make intrameniscus refreshment without penetration of the surface, and plan to do the repair. Now, look here, if we go like this is very weak repair. And you know the principles of AO, of interfragmentary screw compressions, yeah, of the fracture, lag screw, you have to be perpendicular. So here, the best also to be perpendicular. So we went inside, make the vertical suture. I use either scorpion or nowadays I more use lasso because it's more gentle to the meniscus. And after passing the suture, take the suture out, I pass the PDS loop, and you see, we will take the loop, pass the first limb of the suture inside the loop, and now after that, we go back to the needle, to the capsule, not out of the skin, shift it up, advance, and now we will load the other suture inside the loop. And it needs some experience, this technique, especially shoulder surgeon, they can do it easily. So after that, we pull the needle and the BDS suture. You see, we take both limbs together out of the skin, through small skin puncture. So it's very stable, vertical, strong fixation. Another case, look here, this is a complex tear of root tear with a body tear of the lateral meniscus, and we use the suture as a reduction tool. So we reduce it and make testing when tension on the body and the root, and if we accept that, we agree that it's good, we can proceed, otherwise we can modify our sutures. So this is can use for reduction and testing reduction. Now back to our case, this is a complex tear. So the question, which technique? Sure, we would prefer circumferential suture, and I usually do testing for reduction, like in rotator cuff surgery. Now we always do refreshment, take care of the biology, and after that, look, we added many circumferential suture. This is the first one, this is the second, and because it's complex, this is a vertical suture to suture to the capsule. And now we have two sutures above and two sutures below passing out to the capsule, what we call the limited capsular bridge. And we make knot tying using small puncture wound using the knot pusher. And here, during the surgical technique. So look, the result is excellent, well reduced and well repaired meniscus. We always do near synovectomy or synovial abrasion and microfractures. And it's very important to take care of biology. You have a healthy bed for repair, so we can use shaver with caution, rasp, needles for vascular channels, and to have healthy bed for repair, and near synovectomy. And look, in this case, look how many stitches we can use by this technique. And here, this was part of ACR reconstruction with Moptec. And you see here how far posterior is the suture using this technique safely without risk of saphenous nerve injury. Now back to this case, who will do repair? Now, she's old, yes, but we know that if you do resection or nothing, this means functionless meniscus, this means persistent pain, progressive osteoarthrosis, and the patient will leave totally. So what I did, this was many years ago, so I did it repair with simple BDS suture with the traditional techniques, and the patient come back to my clinic after 4 years complaining of shoulder pain. Unfortunately, she has no knee pain, alhamdulillah. So we have to work hardly, and by conclusion, preserve the meniscus, repair even repairable meniscus, residual meniscus. If you resect part and you can repair part, repair it please. Take care of root tear and radial tear because this will lead to functionless meniscus. Take care of biomechanics, alignment and stability. Don't forget biology, and limited capsule bridge technique is a strong, safe, and cost-effective repair technique. Thank you.
Thank you very much, Dr. As'ad. Always giving us interesting talks. Actually, Dr. Prof. helped